Hello, welcome everybody to this webinar dedicated to thrombotic microangiopathies in the setting of systemic diseases. So, as a reminder, the term thrombotic microangiopathy encompasses a group of diseases characterized by the association of a microangiopathic hemolytic anemia, a peripheral thrombocytopenia, and organ failure of variable severity. And among this group of diseases, one can identify specific diseases on the basis of their pathophysiology. So one can identify thrombotic thrombocytopenic purpura, or TTP, which can be either congenital or autoimmune, the hemolytic uremic syndrome, or HUS, which can be either associated with infections or a dysregulation of the complement pathway, and a third group composed of various entities that may act as triggering factors to induce a thrombotic microangiopathy. And within this group of thrombotic microangiopathies are the patients with a systemic autoimmune disease. So there is some controversy about the boundary between HUS and these secondary thrombotic microangiopathies, because on these latter patients, Adams-13 activity is usually detectable or normal, renal involvement is prevalent, and some authors may link those patients to the group of HUS diseases. So let's start by TTP, which is a specific form of thrombotic microangiopathy characterized by a profound thrombocytopenia, typically below 30,000, and severe Adams-13 deficiency, which is a specific biomarker of the disease. This deficiency may be either congenital and due to biallelic mutations of the encoding gene, and this disease was formerly called the Upshaw-Schulman syndrome before we were aware about this enzyme deficiency. And this disease typically occurs in neonates as well as in childbearing age women when they present typically a first pregnancy. The other more common or less rare form of the disease is the autoimmune form of TTP, which here again is very rare, as the incidence does not exceed some cases per million inhabitants per year. This is a picture that shows the clinical difference between TTP and HUS, and this is important to distinguish one disease from the other in real time, in emergency, when Adams-13 activity is not available in real time, which is the case for most countries in the world. So you can see that those patients with TTP have again a lower platelet count, and on the opposite, a mild renal involvement, as opposed to patients with HUS who have a severe renal involvement. And this difference between the two diseases regarding platelet count and renal function, again, could lead to the development of predictive clinical scores able to predict a severe Adams-13 deficiency in real time to start in emergency targeted treatments. This is to show that patients with TTP may have a disease associated or not with a specific context. And you can see here from our experience that half of patients may have an associated context, including an infection, an autoimmune disease, and a pregnancy for most of cases. This is a focus on the autoimmune and systemic diseases in the setting of autoimmune TTP. And in this work, we had reported from 261 patients with autoimmune TTP that in 26 cases, so 10% of patients, an autoimmune disease had been identified before the diagnosis of TTP. In 17 cases, the autoimmune disease and the TTP were diagnosed concomitantly, and in 17 other cases, the autoimmune disease occurred after the diagnosis of TTP within 22 months and 12 years following the acute phase of TTP. And you can see in this table that systemic lupus erythematosus and Sjögren's syndrome are the two most common systemic diseases observed in association with TTP. This is to show that at the acute phase of TTP, one can find frequently antinuclear antibodies in around 50% of cases. And interestingly, patients with anti-SSA antibodies and those with anti-DNA antibodies are more prone to develop a systemic disease during follow-up. So it is recommended now to search for these antibodies in a patient with TTP at the acute phase to evaluate the risk of evolution to an autoimmune disease during follow-up. By the way, these antibodies were not found to have any prognostic role at the acute phase of the TTP. We could find some alleles in the HLA system that are either protective or that expose patients to the risk of TTP. And interestingly, we could find that the DRB111 is an allele which is strongly associated with the risk of TTP. So these alleles exposes patients to a loss of tolerance of the immune system against adamantine. On the opposite, the DRB14 is an allele which is protective against TTP. This is what one has to keep in mind to understand the treatment of TTP. So those patients have a severe antibody-mediated adamantine deficiency, which leads to the accumulation of high molecular weight von Willebrand factor multimers. And these multimers are highly adhesive towards platelets, especially in the microvasculature where VWF is present as a string. And these strings will be able to interact easily with platelets due to high shear stress in the microvessels. So this context leads to the death of the patient if an adapted treatment is not rapidly proposed. So on the basis of these findings, there is a need in this patient to replenish adamantine levels, to saturate anti-adamantine antibodies, and to cleave the large VWF antibodies. And this can be achieved with a plasma exchange that brings to the patients large volumes of plasma and then large volumes of adamantine. The second strategy is immunomodulation that allows to block the formation of antibodies against adamantine. And here one can be more or less specific with the use of rituximab against B cells, cyclosporine against T cells, and anti-plasma cells such as proteasome inhibitors like bortezomib. The third strategy consists in inhibiting the pathologic interaction between platelets and VWF, and this could be recently achieved with the use of the nanobody caplacizumab that targets the A1 domain of VWF and prevents its interaction with the GP1B on platelets. This is the standard treatment of autoimmune TTP, and actually the historical treatment of the disease, which consists in daily plasma exchange and steroids in emergency until remission. And this has been the core treatment of TTP for more than 30 years now. And notably with this regimen, the prognosis of the disease was outstandingly improved, as before the systematic use of this regimen, almost all patients died from the disease, whereas with the systematic use of this regimen, more than 85% of patients can recover from the disease. However, there were some unmet needs with the standard treatment. First, patient could experience exacerbations of the disease in up to 50% of cases and refractoriness in 10% of cases. So in both of these conditions, despite an adapted treatment, patients experience a worsening of the disease or a lack of response, and this exposes them to more treatment, to more hospitalization, and to a higher risk of death and a higher risk of treatment-related complications. So in this context, we started to evaluate the efficacy of immunomodulation to block the formation of antibodies against LAMP13, and rituximab was, of course, an attractive compound. And the use of rituximab first as a salvage therapy in those patients with an unfavorable outcome on the plasma exchange could show that with the use of rituximab we could prevent long-term responses to plasma exchange. And clearly, the systematic use of rituximab as a salvage therapy in these patients could limit the duration of plasma exchange treatment in these patients. So we could prevent long-term responses in those patients. The bad news was that rituximab is not efficient in real time in these patients. And between the first rituximab infusion and the durable platelet count normalization, there are 2 weeks during which patients can still present an unfavorable outcome, including deaths. So there was a need to find a compound in these patients to protect patients during this 2-week period until rituximab improves ADAMTS13 activity. The other interesting point with the use of rituximab was that rituximab is able to remarkably protect patients from early relapses after the acute phase. And you can see in this picture that, look at the black curve, patients who receive systematically rituximab in association with a plasma exchange and steroids do not relapse during 12 to 18 months after the acute phase. On the opposite, patients who do not receive rituximab are prone to relapse rapidly after the acute phase. So on the basis of this result, it is now highly recommended to propose rituximab systematically to those patients with TTP at the acute phase in association with plasma exchange and steroids. So the last step of the TTP treatment is the fact that we can now propose to this patient a treatment with a capecitabine, and this compound was evaluated on 2 international randomized controlled trials, which led to the registration of the agent as a compound for the treatment of TTP on diagnosis at the acute phase in association with the standard treatment. And in France, during an early access program period, we could assess the efficacy and the tolerance of capecitabine in association with immunosuppression and plasma exchange. So this is the detail of the regimen of the treatment we offer to these patients. We called this regimen the Caplavie regimen, which, as you see, associates triplet strategy with a plasma exchange, immunosuppression with corticosteroids and rituximab and caplacizumab. So these are the clinical data of the patients we treated with this triplet regimen. We could treat 90 patients with this triplet regimen within 18 months. And we compared the data of these patients to a historical cohort composed of 180 patients. And you can see on this slide, interestingly, that the clinical features of these patients were strictly comparable. Regarding clinical presentation, cerebral involvement, cardiac involvement, and so on. And here, regarding biological findings, again, both groups were comparable. Steroids were offered to both groups of patients equally. Rituximab, by definition, was offered to all patients in the triplet regimen and in 68% of patients in the historical cohort, because here rituximab was used as a salvage therapy and not frontline. And here you can see the results that were recently published. The primary outcome of this study was a composite of death and refractoriness. And you can see that two patients out of 90 in the triplet regimen reached this primary outcome versus 22 in the historical cohort. And regarding secondary outcomes, you can see that we observe more deaths in the historical cohort versus in the triplet regimen. And we also observe more refractoriness in the historical cohorts and more exacerbations versus patients in the triplet regimen. So clearly, with the systematic use of caplacizumab, but also rituximab frontline, we could prevent remarkably unfavorable outcomes in these patients. In green are the data that show that this triplet regimen allowed to decrease the burden of care in these patients. And the triplet regimen allowed to decrease by twofold the number of plasma exchange sessions and the related plasma volume. And we also decreased by twofold the duration of hospitalization. So these are very nice results. And from this data, this triplet regimen should become the new standard of treatment in autoimmune TTP. So let's move now to the prevention of relapses in these patients, which is a major goal, since these patients at each relapse may experience death, simply. They may experience treatment complications, as well as neurological sequelae, especially neuropsychiatric disturbances that are increasingly reported in these patients. So here the strategy was to offer to patients who experience an episode of TTP, but who experience during follow-up a drop in adamantine activity, a preemptive infusion of rituximab to improve the enzyme activity. And these are the results of this strategy. Clearly, it works. As you can see that historically, in those patients with a persistent severe adamantine deficiency and not otherwise managed, the risk of relapse was prevalent. You can see from 23 patients left with a severe adamantine deficiency that 17 clinical relapses occurred. In 11 patients, these relapses were repeated, and in 2 patients, deaths occurred. On the opposite, you can see that on those patients in whom rituximab was systematically offered when adamantine activity dropped, the curve is shift from to the top to prevent most of the relapses. So with this strategy, we are now significantly changing the epidemiology of the disease in our country, since we do not observe relapses anymore, almost anymore, in these patients. So we now systematically treat those patients preemptively with rituximab when adenosine activity drops during follow-up. So you can see that we are moving in this disease to a targeted strategy that addresses the three pillars of the pathophysiology of the disease. We supply patients with ADAMTS30 through plasma exchange, and soon we hope with the recombinant form of ADAMTS13, which is under investigation. We offer these patients immunosuppression to block the formation of anti-ADAMTS13 antibodies with steroids and rituximab, and we prevent the pathologic interaction between platelets and VWF with caplacizumab. So again, this triplet regimen has become the standard treatment, the new standard treatment, at least in France, for the management of TTP. So, as a conclusion of this part, autoimmune TTP is an archetype of autoimmune disease that represents a nice model to understand the immunopathogenesis of autoimmune diseases and a convincing example of the success of translational medicine. As you can see, increasing compounds such as caplacizumab and soon the recombinant form of ADAMTS13 should still more improve the management and the prognosis of this disease. And clearly, these new therapies, as you can observe, were derived from a better understanding of TTP pathophysiology, reflecting a shift from empiricism to targeted therapies, making TTP as a disease that has fully entered the era of personalized medicine. So I will now say some words about HUS associated with systemic diseases. I will go faster on this part of the speak because we have less data. This is to remind you that the term HUS also encompasses various diseases. This term encompasses atypical HUS, which is associated with various abnormalities of genes encoding for proteins regulating the complement pathway. Patients with other genetic abnormalities, including mutations of deacetylglycerol kinase epsilon gene, and mutations of genes involved in the metabolism of cobalamin C. The second group of diseases is HUS associated with infections, especially Shiga toxin-associated HUS, as well as HUS associated with Streptococcus pneumoniae and HUS associated with various viruses, as well as this famous third group of patients with TMA or HUS associated with strong triggering factors, including bone marrow transplantation, cancer, autoimmune diseases, and so on. So again, some of these diseases are clearly associated with a dysregulation of the complement pathway. And other diseases are possibly, but not clearly associated with complement dysfunction. And this includes patients with Shiga toxin-associated HUS, patients with hematopoietic stem cell-associated HUS, and those patients with HUS and no obvious abnormality of the complement pathway, but who respond to anti-complement therapies, suggesting that to a certain extent the complement system is involved in the pathophysiology of these patients. So those patients with a genetic abnormality have a more chronic disease, which outcome is characterized by chronic relapses, whereas patients with a triggering factor are more transient, and in this disease there's a need to control the triggering factor to improve the outcome of the patients. This is a summary of the pathophysiology of complement-associated HOS. And this is to say that in the complement system, as you know, you have the classical pathway activated by immune complexes that lead to the formation of the classical C3 convertase, which is the C4b2A, and the alternative pathway, which leads to the formation of the alternative C3 convertase, the C3bbb. And in this pathway, which is activated by microbial surfaces, the C3 component is spontaneously cleaved on C3b in plasma, but when C3b meets the microbial surfaces, it binds to factor B, which is activated in factor BB, and this C3bbb is the C3 convertase that cleaves C3 on C3b. And this C3bbb will again cleave the C3 through a retrocontroller pathway. And this activating loop is very efficient to fight against microbes, but it needs to be tightly regulated by various proteins, such as factor H, I, CD46, and regarding these proteins, these 20 last years, three main abnormalities were described. The first one are inhibitory mutations in these inhibitors of the alternative pathway. So these are inhibitory mutations on factor H, factor I, and CD46. And the result of these abnormalities is an overactivation of the alternative pathway. The second kind of abnormality are activating mutations on accelerators of the alternative pathway involving mutations of factor B and factor C3. And the third kind of abnormality are antibodies directed against factor H that block the function of factor H. So all these abnormalities encompass up to 70% of abnormalities in atypical HOS and lead to the deposit on endothelial surface of complement compounds that activate the endothelial cells and lead to the expression at the endothelial cell surface of pro-coagulant and aggregant factors. And this leads to the formation of microthrombi. This is to remind you the horrible prognosis of atypical HOS before the era of complement blockers. You can see on these curves reflecting end-stage renal disease and death, that patients with mutations in factor H had a very bad prognosis since these patients experience frequently death or end-stage renal disease in most cases, whereas patients with mutations of CD46 had a slightly better prognosis. And you can see all the other abnormalities that were associated with more or less a bad prognosis. But with the use of complement blockers, the outcome of this patient was outstandingly improved. And eculizumab is a monoclonal antibody able to block the cleavage of C5. And this compound was used in atypical HOS through a prospective trial. And you can see here the summary of the results of this trial that showed that in patients with atypical HUS who were refractory to plasma exchange or dependent on plasma exchange, the administration of eculizumab to these patients improved nicely the platelet count and durably throughout the time, with substantial improvement in renal function that could stop the use of hemodialysis in those patients. So the outcome of this patient was again outstandingly improved with eculizumab. And now the forthcoming question in this field are to address the use of more long half-life compounds such as ravulizumab. And very recently, studies showed that ravulizumab, which is administered every 2 months instead of every 2 weeks, each is at least as efficient as eculizumab. And now I will focus on the epidemiology of HUS associated with systemic diseases. This is quite a rare condition in the field of secondary TMAs, and you can see on this epidemiological study that patients with HUS associated with a systemic disease represent 9% of the world patients. And in order to focus on these patients, we could study 41 such patients with an HUS associated with a systemic disease from our registry. And from this purely descriptive study, we could find here again that the most frequent systemic diseases that occur in the setting of HUS are the systemic lupus erythematosus, the Sjögren's syndrome, and the systemic sclerosis. There are some overlap syndromes. Kidney biopsy, of course, identified mostly glomerular findings. And clinically, those patients with HUS associated with a systemic disease have more frequently a pre-existing kidney disease, which is expected as they have an underlying autoimmune disease. But on the opposite, the renal involvement is less severe when compared to those two patients with an atypical HUS. Regarding treatment, the data are very scarce because the treatment modalities were very heterogeneous. And the main message one could keep in mind is that there is no obvious efficacy of plasma exchange in these patients, and the most efficient strategy to control the thrombotic microangiopathy in these patients is to treat and control the underlying systemic disease. And we observed that in most of the patients who could remit from the TMA, those patients could remit after the systemic disease was controlled with immunosuppressants. So there's now a need to better focus on these patients to better characterize the clinical picture of this condition and to better address the question as to whether plasma exchange and eculizumab could be of help in the control of the TMA. Thank you for your attention, and I wish you a good evening. Thank you.